call upon Dr. Deepak Bhatt. He is a practicing exclusive ophthalmic ultrasound, though he's a radiologist, and he's a visiting ophthalmic sonologist at Grant Medical College. And he'll be talking to us about the role of OCTA in glaucoma.
Okay, we all know that glaucoma is a complex situation. We heard about multiple investigations. I'm going to add 2 more investigations to that. I don't know whether it's going to add to the confusion or probably solve the problem, because it's still a disease which we have still not understood. Anyway, we all know that the vascular part in glaucoma plays a very important role, and we still not been able to decipher exactly where the vascularity is a problem. So we have the arcades, the superior and the inferior arcades giving up the radial peripapillary capillaries, and then you have the superficial and the deep plexus. So the radial peripapillary capillaries is what we see in the nerve fiber layer, okay, and the superficial are seen in the ganglion cell layer. How do we see that? Now we have these 2 pictures here of FFA and OCT angio. We couldn't really see the capillaries well on FFA. OCT angio has helped us to see those capillaries really well. How is it useful? We'll see that now. So you have 2 pictures here from the macula and from the optic disc. Now this is a little older version. The new one has the 2 to combine together. And we can combine this 2 together and get a good picture of the circulation around the optic disc. Now see, there are 2 groups of blood vessels here. These radially going vessels which are along the arcades here are the radial peripapillary capillaries, and these branching pattern that you see here is the superficial plexus, okay? Now, what we do in our routine RNFL analysis is what we see as the radial peripapillary capillaries. So if you see here, these are only the radial peripapillary capillaries. They can be quantified sorry, with color coding, and you can see only all these red lines are radial peripapillary capillaries. And these are the first ones to be affected because of glaucoma, right? Now this is a normal fellow. This is a little older software. Now you have the newer software in this machine. And this is the capillary density, which tells us around 19.2, 18.6. So something between 18 and 20 is normal. We really do not have a normative database for it ready as of now. And we can have a color-coded thing again to show us what is happening. So let's start with cases as such. That was the normal evaluation. So you have structure and functional correlation between the vascularity and the structure. See here, this is the inferior defect which is along the arcades, and see this structure here. You are seeing the radial peripapillary is gone along the arcades, but they are present superiorly. Even the quantification of 18.9 here, 16.1. Don't go by the numbers. It is actually more of follow-up when no normative database really ready here. Another case actually of the glaucoma on the other eye of this patient, you have a structural change seen on OCT, and does it correlate with the what we see on angio? Yes, it does. If you see, you can see the branching vessels over here, but the radial peripapillary capillaries are seen at this edge from this edge. It is not seen in this particular area, but it is seen superiorly. So this is the area where it is deficient. I have just enlarged this image to show that you can see only the superficial plexus and not the RPC. But they are seen in the superior quadrant. So it's one more addition to what we are really seeing. And the same thing can be color-coded and seen very well. Okay, now just another case. We had a case of AION where on the right side, patient was hypertensive, and you could see that there is a loss of RNFL and the ganglion cell layer on the right, whereas the left looks fine. Even the patient had a significant visual disturbance on the right side. And if you do an angio over here, again you can see that the superficial area is still some amount not seen, but there is severe loss, 13.6 over here, and there are no radial peripapillary capillaries in the inferior quadrant. So this was a cause, probably more of a vascular component, because there is significant loss into this. There is a structural function correlation definitely there. But when we came out with this Zeiss has come out with this new software, which is 4x4 into 4x4. This is primarily for the RPC only, the radial peripapillary capillaries. And you have the 2 indices. One is P and F. Very simple. P tells you the percentage of the capillaries present in the superior arcade. And F is really the brightness. I mean, I cannot rely too much on F because OCT does not quantify the amount of blood flow. It frankly tells us whether it is yes or no. We have not reached that stage of quantification because physics only of the OCT angio does not tell you that there is how much quantification. But yes, there is brightness which can be deciphered from 0 to 1, and somewhere within 0.55 is considered as normal. So this is how normally the new software now works. You have a normal patient here, and around 40, 45 is considered okay. Still the normative database is not allowed, and below 40 is considered to be abnormal. So you have the patient here where there is some amount of structural change seen on the left side, and I wanted to see whether there is a change or not. If you see there are these values 40 and 42, they are still in the normal, lower range of normal, but there is some amount of loss of the capillaries here. So there is definitely correlation at the very early stage. All the articles that I have read, they say that in the early stage there is a correlation between OCTA and OCT, but in the later stage is where it is difficult to really make out. Same patient, the other eye, you can see that there is a significant superior loss on OCT, and you look at the values here on the superior side, 37.2, whereas it is 40 on the lower side. Okay, so there is one more addition to our armamentarium. A severe loss of function on the left side with it's 67, 68 here, and you can see that there's almost loss of the capillaries along the arcades. Even the superficial plexus are gone. Therefore, we are seeing this white hue, which is actually the deep plexus coming up. The values are 32 and 34. Okay, now I'm going to introduce one more topic with the permission of Zeiss here, one more investigation which can be added inside to our study of the glaucoma. Something happens beyond the optic disc behind, which also affects the function of the optic disc. We have a patient with normal tension glaucoma, had a family history of normal tension, very strong family history. Patient was on regular follow-ups. His right fields remained steady. He was a very intelligent patient, had continuous follow-up being done. Left started deteriorating. This was the HRT, which shows that it's stable, much stable on the right side, whereas the left started deteriorating over a period of time. His vision was very well maintained, but he was a regular follow-up, and we could definitely see these changes. Perimetry started showing changes on the left side. Right side still looks okay. There was something happening on the left side. So we investigated further. OCT was absolutely normal. These ranges are way beyond any doubt of anything happening over there. So we did an OCT angio, which also showed maybe a little bit reduction, 15.3 here, 17, some changes on the left side, but we can't be sure because we are still seeing RPCs going on out here. So we did color Doppler of this patient here. You can definitely, it's color Doppler RDN at 2 levels, at the ophthalmic artery level and at the central retinal artery level. You can see that changes happening here in the ophthalmic circulation. Here, the end diastolic values. I don't want to go into the details of these values here because it's too much to in this talk, but it's 12.1 here and 9.6. Within 10 to 11 is accepted ranges or normal. It's a very small range of normality. There is a resistivity index, which really tells us how much of the blood flow is inside this artery, is also low on the left side, and it's normal on the right side. The same thing can be done for the central retinal arteries involvement here. The PSV is 7.5, and it is 6 on this side. So there is a problem which is occurring beyond the optic disc, and apart from the color Doppler, there is no way which we can make it out. Another patient where there was extensive disc damage. Now look here, there can be plus and minuses everywhere. The OCT angio still looks pretty okay, 45, 40, this is an accepted still range, but see the disc, patient had loss of vision. And then we went on to do the color Doppler. It has severely affected arteries. On both sides, you can see that the RI is 0.7, EV is around 11, even 9.6 on the left side. Central retinal artery values are also involved. And therefore, there is something happening which is behind, which we could not explain. So within this patient, we even tried to study the posterior ciliary arteries, and there was low flow, end diastolic flow. Means that there is resistance to the flow into the circulation. Now, what I want to conclude is, I don't want to add to the whole gamut over here. It's studying the circulation around the optic disc is a very complex phenomena. Harry started it way back, and he has done a lot of work, which still stands good. But only looking at clinically and OCT and OCT angio may not probably give us the full answer, because there are some vascular causes beyond the optic nerve which clinically or no way cannot be made out. But an Doppler is also a test which can be added to it to give us a diagnosis. Whether we can do something for the patient or not, we do not know, but it's an added investigation which can at least point what is going on. So OCTA cannot be used solely as a single investigation. It has to be used in the combination. So we are adding now OCT, perimetry, OCTA, and color Doppler to the system. Thank you very much.